All right. Good morning, everybody. Welcome to a comparative ocular pathology rounds here in this lovely fall morning, October 2nd, 2024. I'm going to go ahead and get started. My name is Dr. Jamie Miller. I'm one of the pathologists here at Coplow. And the first case I have for you today is the right globe from a 5-year, 6-month-old male neutered domestic short-haired cat. The history for this cat is that it had unilateral anterior uveitis with fibrin and cataract formation starting in February of this year. There was no history of trauma, and blood work was within normal limits. The inflammation did not fully resolve with topical anti-inflammatory drops, and the cataract progressed over 4 months. So they elected to do cataract surgery and perform that at the end of June. The uveitis worsened after surgery with obvious hypopia on 1 week post-op. They were suspicious for bacterial endophthalmitis, so they started oral antibiotics, but it did not improve. And therefore, the pseudophakic lens that they had placed with the cataract surgery was removed at the end of July. The uveitis persisted despite their efforts, and iris bombé developed. And so the owner elected enucleation due to impending glaucoma development, because at the time IOP was 11 and there was no glaucoma noted. So we got the right globe here, and this is the hemisection view of our globe with the cornea up at the top. There is no lens and no intraocular lens in place. As they said, they took, after the surgery, they went back in and took out that lens. So we have a lot of white material here in the anterior chamber. Our iris leaflets here are kind of thick. Our retina is detached here and very thick, and we've got a very cloudy, almost opaque vitreous here. And we can't really tell what's going on with the optic nerve. So let's take a look at what this looks like histologically. Do a subgross here. I can do that without my hand shaking here too much. Here is our cornea up at the top, not looking too bad. Here is some eosinophilic cellular material here in the anterior chamber, matching that yellow stuff that we saw grossly. Here is our very thickened and distorted iris and ciliary body coming down here. We still see a little bit of the uveal tract pigment. Again, no lens, and got a little bit of proteinaceous material here in the vitreous, a little bit of lens capsule here left, this bright eosinophilic membrane. And here's our detached retina. It's also torn. It's got a nice little rounded end. And we can see our choroid here is a little bit thickened as well. And we can see this cellular infiltrate kind of comes back here into the optic nerve head, but does not extend to the optic nerve margin. This is a little extra radial section that we often take from our globes, just so we can evaluate for goniodysogenesis oftentimes, and also get another look at what's going on in the globe. Zoom in a little bit for you guys. All right. So as we walk around, let's see, we'll get towards the front. Here's our cornea here to the right. Wasn't looking too bad. Here's our iris, again, very thick, very infiltrated by a lot of blue dots, a lot of cellular infiltrate. We've got these large areas of eosinophilic cellular debris, so a lot of necrosis going on in here. Here is our lens capsule. You can see the anterior lens capsule is thickened. We have the posterior lens capsule here, a little bit wrinkled. We've got a little boxy end at the equator here, which is a good indication that an IOL was in place at one time. An intraocular lens, thank you. Defining my acronyms. So as we keep walking here, You can see here's the other end of the lens capsule. And as we walk around the globe, the cellular infiltrate ends are all the way around. It faces the choroid, again, with a lot of necrosis. And our cellular infiltrate is also here within the retina and really distorts the retina. And so if we zoom in on these cells, you can see a very pleomorphic population of round cells. So we've got some smaller round cells, we've got some larger round cells, we've got some cells here that have multiple nuclei, so some multinucleated cells. We've got eosinophilic cytoplasm. Again, variation in size and nuclear features. This here, we're actually in the limbus, this actually ends up being some suture material from, I'm assuming, one of the previous surgeries that they did going into this globe. And these cells are all over. Let's see if we go closer. Some of the neoplastic cells do have some pigment in them, some melanin pigment. Here's kind of a very bizarre looking mitotic figure, so very mitotically active. So we've got a neoplastic population of cells. We had a lot of surgery in this eye. And the other thing is that the cells kind of circumferentially expand and efface the structures of the globe. And that's kind of a pattern that we see with like post-traumatic events, especially in cats. Again, back here in the retina, all the neoplastic cells are infiltrating here as well. So it was a little bit odd because these are round cells and they weren't wearing clear name tags as to who they were. We had some suspicions. Lymphoma was probably one of the top ones because that's often what happens. We got infiltration of the retina. That's something that lymphoma likes to do. The odd thing is that the multinucleated cells and the larger cells maybe aren't as common with lymphoma. It made us think about histiocytic sarcoma. And with some of the neoplastic cells containing pigment in them, we also considered a malignant melanoma, although they could be phagocytosing pigment from all of the necrosis going on in the eye. So we offered a battery of immunohistochemistry for these neoplastic cells, CD3 and CD20 for our T and B lymphocytes respectively. CD204 for histiocytes and a melon A for potential melanocytes. And thankfully, they decided to run all markers on the cells. So I have a very good answer for you guys. So I'm going to start with the CD3 since lymphoma was maybe higher on our differential list. Let's see if I can do this. I'm just show a subgross here. So we can see that there is some brown staining here. It's kind of scattered. It is kind of throughout, everywhere. But if we look closer, again, this is our CD3 for T lymphocytes. Linked over here. Okay, we can see that we have some smaller positive staining cells that are kind of scattered about. But our larger pleomorphic looking neoplastic cells are not staining. So these are probably inflammatory or tumor-associated T lymphocytes in here. So same thing with the CD20 for B lymphocytes. I will tell you it had the same similar subgross pattern as the CD3. And again, looking closer, there are some positive staining cells in here, but a lot of the larger, more pleomorphic neoplastic cells and multinucleated cells are not positive. So Then we got to the CD204 for our histiocytes. And this was kind of a subgross, almost diagnosis. We can see how diffusely and strongly positive all of these neoplastic cells are in the globe.
It's a bit higher.
Yeah, so even the big multinucleated cells are positive in this case. So we've got nice, strong cytoplasmic staining for the CD204.
It's gonna just leave there and focus
Yeah.
a little bit. There you go.
Yeah.
Just because it takes a little bit on the
Thank you.
online to.
Yeah, so here's our multinucleated cells. So this is consistent with a histiocytic sarcoma. The CD3, CD20 did show kind of a background of inflammation throughout the uveal tract too. And I'll spare you showing the slide, but the melanoma was negative for these neoplastic cells. So a histiocytic sarcoma in this cat, it's so our diagnoses, this was a status post-operative cataract surgery with IOL placement, followed by IOL removal, the intraocular lens. And then, yeah, and then there's the intraocular histiocytic sarcoma, again, with features of post-traumatic sarcoma, given the circumferential and the destructive nature of it. It wasn't clear if there was truly neoplastic cells like within the remnant lens capsule. So it's hard to tell if this was here beforehand or if this is truly something that kind of developed after the quote unquote trauma to the eye with the surgeries.
Yeah, the
So
reason that I chuckled was as soon as it finished, Dr. D jumped in as I expect him to do if he were sitting right next to us and ask, can we call this a post-traumatic histiocytic sarcoma? So yeah, that's the main thing. It's these are obviously not from the lens epithelium, as you'd see the classic spindle cell version of the post-traumatic sarcoma. We've seen round cell tumors associated with chronic ocular inflammation, or that may or may not be associated with trauma in cats specifically. But those have been shown to be lymphomas. That's the first one that it's obviously not lymphoma. It's definitely histiocytic. The histochemical markers are obviously point towards that. Some morphology point towards that. Now, exactly what Jamie said, we don't know if it was just a serendipity that it happened in and around the time that they had made a phaco emulsification on this cat, or not. So we are unsure. The one thing that is interesting is the distribution of this tumor. It's very much unlike the histiocytic sarcomas we see in cats. They tend to be more well delineated masses. This is circumferential, infiltrating everything, infiltrating the retina, and behaving like a post-traumatic sarcoma would. So, yeah, I don't know. Calling tumors post-traumatic in general is already a contentious topic. If you're going to add a histiocytic sarcoma to the menu now, that's what it looks like. I'm not, you know what I mean? And we were talking about it. I'm glad that IHC was very, very obvious, because otherwise I don't think we would have been able to make that call if the CD3 and CD20 were not obviously staying just inflammatory cells, and if the cells were not diffusely positive for CD204, I think we would have been a little more hesitant. But it's very sharp and very clear. So of course, the clinician called me right away after we sent a report out, because I would call myself if I read a report like that. So we talked, so this cat is under the care of an oncologist right now. The interesting follow-up is that they haven't seen any systemic disease in this cat, so it doesn't seem to be a disseminated histiocytic sarcoma, which again point more towards a primary ocular tumor. And in this situation, like a post-traumatic histiocytic sarcoma. There you go, I said it. So very interesting case. It's a one of one. I told the clinician, often you guys see that? I was like, never. That's your first. So we agreed to have a close follow-up in this case, and if something comes up, we'll let you guys know, because this is kind of cool.
So the follow-up question to that would be, how often do you see intraocular histiocytic sarcomas in cats in general?
Megan, do you remember the numbers from the case series
do.
we put together? So the question was, how often do we see histiocytic sarcomas in cats?
Yeah,
Ocular
so
histiocytic sarcomas in cats.
we had a bit of a project going, and by 2018, there were only 12 cases in the entirety of the Coplow's database. We absolutely have more than 12 now, but I can't imagine that we have much more than 12. So it's probably less than 20, it would be my guess.
Yeah, so it's rare to begin with.
Numbers are insufficient to make conclusions.
Yeah.
Indeed. For what it's worth, the 12 we had a much longer survival time in general than dogs. But yeah, small sample size.
All
Cool.
right,
Good
excellent.
way to start.
Kick it off.
All right.
Sticking with a cataract surgery theme, I suppose. This next case is the right eye from a northern pin-tailed duck from a captive facility. All right, so the history is that this duck had bilateral phacoemulsification back in October of 2023. The left eye was routine. The right eye required a lens capsular removal. It represented at the end of June of 2024 for weight loss. At that time, the right eye had diffuse corneal edema, blepharospasm, and increased use of the third eyelid. Pressures were a little bit elevated in the eye, 36 to 38. They started treatment at that time with oral pain control, and the pressures improved to around 25. The corneal edema also improved, but I guess they decided that they were still going to take the eye because they elected routine enucleation of this globe. There are no other medical conditions outside the weight loss, which they suspected to be secondary to vision loss and discomfort. Blood work was normal, so they took the eye. So this is, again, hemisection view of our pin-tailed duck eye. We've got cornea up here, uveal tract here. See, I don't think there was much. The vitreous was a little bit thin. Cornea, again, was kind of cloudy, as they had said. We didn't see the lens, and that was, I think, about it. We did have to decalcify the globe because they've got scleral ossicles, which we'll take a look up here. So some bone up in the front around the limbus there.
There wasn't any amyloidosis in the history.
No history of amyloidosis. Nope. No history of amyloidosis. All right. So here is our subgross. It does have a little bit of an hourglass figure. Oh my goodness. Okay, cornea up here. Here's our little iris leaflets, our optic nerve. This is a little bit more, a little bit cupped, kind of vacuolated looking. Sorry. Up here, the scleral ossicles, we can see these bright eosinophilic, bony regions. And then as we also look at the back of the globe, we notice some bright eosinophilic material back here that looks very similar to the ossicles up front. So we will take a look at that as well. All right. So we'll start up here in the cornea. So we can see our corneal epithelium here, a little bit hyperplastic. We've got these granulocytes in here with eosinophilic granules, so probably heterophils coming in, and some blood vessels, so a little heterophilic keratitis. And as we head to axially here, that one for a second, we can, as we get to the edge here, we get a region here where the corneal epithelium is disrupted. It's also lifted up from the corneal stroma, and we can see kind of little eddy and whorl formations here in the epithelium. So the epithelium has kind of lost its way, it's lost its polarity. So this is a true detachment from the underlying corneal stroma, and this is what we term indolent ulcer. And as we continue along, we can see a little bit of the inflammation and the vasculature carry on. The corneal stroma is maybe a little bit thin here, and you get a little bit of fibroplasia here, a little bit more spindly cells in here. Our basement membrane is also a little bit prominent here, being exposed to the world. Let's see, we'll walk around. It's a pretty big ulcer here, and here's the other side. Again, our epithelium's kind of lifted up and is a little bit disorganized here. Let's see. We do have a pre-iridoid fibrovascular membrane that comes along here. Very sensitive. On this end, it attaches to Descemet's membrane, so it's creating a peripheral anterior synechia. And the other side here, we can see that that membrane is actually pulling the iris leaflet forward, pulling around the pigmented epithelium here. And so we got some ectropy on uvea. Here's our scleral ossicles here, some nice bone. And then a lot of the sclera also has cartilage around to give it rigidity. Again, no lens, which follows their history of having to go back and remove the capsular surface or capsule that was left here. As we take a look at the retina, it's got very nice layering in it. However, there should be ganglion cells here, and there are none. So there's a diffuse loss of ganglion cells in the retina, and it's a very diffuse process. It's one of those things that you've got to know what's there normally to recognize what's absent. So not having ganglion cells here would be a reason for blindness. I'm going to show this here. We have like a little natural break in the cartilage here, a little foramina where blood vessel is entering or exiting the globe. Our optic nerve is very atrophied and rarefied, and is quite cupped. And if we continue on, we will notice on this side, we have another break in the cartilage. But this time on the outside, we also have bone formation. Goes here. And so this is a true break in our cartilage here that's being shored up by some osteospendoplasia. And if we follow the retina along, we have our pigmented retinal epithelium here, and our retina up here starts to get very atrophied. And if we keep going, there's a loss of the RPE cell and complete atrophy of the retina here. So some sort of trauma, probably traumatic event occurred here at the back of the globe. Very chronic, given the bone formation, and given the location, likely not associated with the cataract surgeries. We couldn't really make that fit with there. So we have kind of an unknown trauma here as well. So it was just kind of interesting find. So again, another postoperative cataract surgery with the lens capsule removal, an ulcerative and heterophilic keratitis with that indolent ulcer and some fibroplasia and vascularization in the stroma. And then that trauma at the back at the globe from some unknown event that probably I don't know, didn't help
Blood
the
trauma.
blunt trauma. So just an interesting case. All right, then I will turn it over to yes.
I was torn between crediting the actual photographer and not revealing who sends us our cases in these rounds. So such is the way it goes. I'm Megan, and this is the first case of the middle. So we have a 12-year-old neutered male domestic medium hair cat. And as you can see from the photo, there is a large pigmented tumor of the upper eyelid conjunctiva, probably also a little bit involving the bulbar conjunctiva of the globe. And we have this mass to look at. That is essentially what we've got here. So the entire globe was removed. This patient was actually exenterated to get rid of this mass. But histologically, we are going to take a look at just the mass. Right, here it is. So to orient you, we have our eyelid over here. So right here, where's our arrow? Right here, we have haired skin. And then it's a little bit stretched out and kind of funny looking, but these big glandular lobules here are meibomian gland, kind of half coming into the plane of section. And probably the meibomian orifice would roughly be at this level. So the eyelid margin is maybe right about here, and then it progresses into conjunctiva from there. So we've got palpebral / bulbar conjunctiva coming around here, and we've got this big tumor infiltrating the substantia propria, forming a really significant and large mass effect in the conjunctiva. It can be kind of variably well delineated. So like over here, it's quite well delineated, otherwise a little bit infiltrative. It's definitely variably pigmented. And if we take a look over here, for example, we have sort of polygonal, maybe sometimes rounded or polygonal or round cells. They have a medium to large amount of cytoplasm. It can be kind of faintly pigmented in some areas. It can be kind of moderately to heavily pigmented in others. It's got what most people will sometimes call the classic owl eyes look. These nuclei kind of look like they're looking at you. So you've got an open chromatin pattern, kind of coarsely clumped, and often a single central nucleolus. I can go higher, yes. There are at least 2 other higher powers. Here we go. Oftentimes these nucleoli are pretty magenta too, which is a sign these cells are pretty active and doing their thing. So this is a melanoma. No need to beat around the bush any further. One very interesting feature of feline conjunctival melanomas, though, is over here in this more heavily pigmented area. Take a look at this cell, for example. This is all one cell. Actually, let's see if we can get it all in the field. There we go. This is all one cell. I'm outlining it roughly like so. Look at this thing. It's a monster. You could spend like an hour counting all the nuclei. There's like 50 in there, rough estimate. Like 50. And you can see there's quite a few of these really, really massive multinucleate giant cells here. Here are some more examples. I'm gonna pick another field and stop, I
That's
swear.
looking back
There
to
we go.
look at the
Yeah,
size of that.
I know. In time for Halloween, it's like a beholder or something like that. But this is a feline conjunctival melanoma, and these truly enormous multinucleate giant cells are kind of a feature of feline conjunctival melanoma for whatever reason. It's not exactly clear why feline conjunctival melanomas tend to be like this in particular. Certainly, you can see a fair pleomorphism in other species conjunctival melanomas, but yeah, these enormous cells seem to be a cat thing. So we don't often get these, even though it's a fairly simplistic and straightforward diagnosis, and just showing off that fairly repeatable feature of these monster cells in this case. That's not it.
Megamelanocytes.
Megamelanocytes.
Murray Shank said. Also, she called them the cells that ate Tokyo.
So yeah, that's it. Simple, straightforward.
Yeah,
Any
the one thing
questions?
that's interesting about these guys that they don't always have those
Good point.
gigantic enormous cells. They often do.
Often.
As a pathologist, if you end up with a small biopsy of a limbal mass or a mass around that region, one of the main differentials would be, a conjunctival melanoma or an intraocular melanocytic tumor that invaded outside and then invaded the eye. The presence of those very large, very unique neoplastic cells might be helpful in making the differentiation, even if you don't know, or if you don't have imaging, of course, that's only a suggestion. The clinician has to help with that. And the reason that's important is that these they seem taking those large ugly cells out of the equation, they might look a little bit more benign looking than the other conjunctival tumors, but they do recur and they can metastasize. So we got to be careful with them.
Yeah, I should have mentioned that. The prognosis. It's kind of similar for a lot of different species, dogs as well. Conjunctival melanomas are usually bad news.
Yeah, but I mean, if you want to see crazy cells, that's the perfect tumor for it.
Indeed. All right. Okay, the next case of the middle is this one. So this is a 4-year-old neutered male pit bull terrier. And in this gross photo, I'm going to point out something that I want you to ignore because that makes a lot of sense, but we'll start with that. This right here is a weird reflection off the cornea, I think. Ignore it. Pretend it's not there. All right, now that we've seen it, we've unseen it. Moving on. So this eye actually came with very little clinical history. Essentially, they just gave us glaucoma in this eye, and that the other eye is okay. And they're wondering if they should prophylactically treat it, and that's about it. Although I think part of that is they say no records care transferred to us for enucleation, so that's part of it. They probably didn't have any information either, also being kept in the dark. But that's the clinical history. The gross description for this case is quite interesting. So one of the really interesting things, dorsal iris severely atrophied or absent, ? Lens not anchored to the ciliary body in this region. And so we can kind of see that right here. It kind of looks like there's no dorsal iris leaflet, right? We've got one iris leaflet over here, then like kind of nothing over here. It's super distorted. The other thing that's interesting is that in the history for this patient, iris color is described as brown. And we do have some pigment in this iris leaflet, but it's almost like there's a layer of like buttercream frosting on top of this iris. It's kind of white tan over the surface here. And then certainly there's a lot of intraocular hemorrhage here as well. So some interesting features.
It's kind of hard because there's hemorrhage, but you can see some melanin there, right? So it's not completely blue, would you say?
Yeah, theoretically, it's a brown looking choroid. Yeah, so usually if it's a blue eye, we'd expect to see kind of a hypopigmented choroid. It usually is recognizable as such. Certainly it's a little obscured by hemorrhage, but yeah, it looks like a brown choroid to me. I would believe them on their brown eye. So things that are of interest. Mhm. My pants are not good for wiping off debris today. They're covered in, actually we'll try subgross first. They're covered in a little dog pattern. Okay, not that anyone needs to know that. Oh wait, there's. So this is a pretty big globe and it's hard to look at even with subgross. So we have our cornea up here, and you can see that the anterior chamber is looking unusually deep, which we could see in the gross as well. And the iris is not looking obviously distorted from low magnification or subgross, but it's a little thick. And you can see that there is something of an iris on this side, maybe, or is this ciliary body? And otherwise it's pretty distorted and weird looking on that side. And that's it. Let's take a look closer and get rid of some of the debris. Okay. Let's start on this side. So this is the side that still kind of had an obvious iris leaflet or so. But you can see that it almost looks like a rabbit and that the ciliary body plica is kind of coming off of the back of what sort of looks like iris. So we have really severe distortion of the anterior uvea. And when we look closer at this uvea, which kind of looks a little thickened, we can see that it's actually occupied by quite a few abnormal cells here. So we have these intersecting streams of spindle cells. Go even closer. And these cells are kind of palisading along the anterior surface of the iris, almost creating like a pseudo-epithelial surface, which is kind of an interesting feature that we sometimes see in these cases. And these cells are generally pretty low pleomorphism, but they're definitely abnormal and not supposed to be here. So this is a neoplastic spindle cell population. We'll come out and say that instead of continuing to beat around the bush. And it is pretty severely distorting the architecture of the anterior uvea. You can see that all the way along here. And if we go over to where it kind of looked grossly like there was no iris, that's because the iris, such as it is sort of plastered against the outside of the globe without much obvious distinction between iris and ciliary body over here, either pretty sharply or pretty severely distorted. And the same neoplastic cells are both infiltrating and expanding the ciliary body and lining or carpeting its surface. On this side of the globe, these cells are looking even more obviously neoplastic with a little bit of elevated pleomorphism compared to where we were otherwise. So like a particularly large nucleus, for example, and another one. Oh yeah, mitotic figure. That one. Wait. That one. All right. Yeah, and mitotic figures. So this is a neoplastic population that's infiltrating, pretty mildly thickening, but severely distorting the anterior uvea. And it's a spindle cell population, generally low pleomorphism, although there are some areas of kind of accentuated pleomorphism like here. A somewhat unusual feature of this particular case is that if we walk over here, we can actually see these neoplastic cells kind of forming these delicate vitreal membranes and slightly lining the epiretinal surface. So they're kind of doing some funny things inside the eye. So ultimately, a neoplasm, I'm actually going to go over here and land on this while I talk. Let's go back over
It's a
here.
good example of tractional retinal detachment, probably the cells
Also that, yeah.
in the retina way.
Okay. So a tumor with this feature, the minimal mass effect and mostly just sort of distorting the architecture, primarily in the anterior uvea, intersecting streams of spindle cells, plus or minus this interesting feature of kind of palisading along surfaces in some areas. All of these features are most consistent with a uveal schwannoma. This was previously called spindle cell tumor of blue-eyed dogs. And it's presumably of Schwann cell origin, kind of the myelinating cells, maybe in like uveal nerves. And it is typically kind of like this. It doesn't really form an obvious mass effect, and many of the cases that we receive aren't necessarily submitted with a suspicion of neoplasia. Some of them are just submitted with a history of glaucoma, like this one was, and kind of
Or uveitis, right?
or uveitis. Yeah, exactly. Like oftentimes, since they're often forming a mass effect, they don't necessarily trigger concern for neoplasia, essentially. This case doesn't really have a good example of it, but some cases even get submitted with a history of a blue eye that turned brown. And the reason that that will sometimes happen is this tumor will sometimes essentially pull the posterior pigmented iris epithelium onto the anterior surface of the iris. And basically that will account for a color change in these irises. Uveal schwannoma of the blue-eyed dogs is called as such because it tends to present most commonly in blue irises. However, this dog is a brown eye, at least as far as we can tell and based on history, which we do have a small number of cases of similar tumors that have presented in brown eyes. So it's not unheard of, just more commonly presenting in blue eyes for whatever reason.
A lot of the ones that I think are brown or have some degree of heterochromia too.
It's a good point. We've also seen it in heterochromia.
Heterochromic eyes that have areas that are blue. But
I'm pretty sure this is a dog we saw.
Oh,
And then I
interesting.
went elsewhere for Enoch. I'm like 90% sure the eye was blue.
Interesting.
Because when we looked at it, it was this big question of, is it something congenital that has always been that way? And so when I
Right.
talked to the owners, they had photos from when they adopted him a few years ago.
And it was blue.
And I have to double check his record, but I'm like 90% sure the eye was blue.
Which may be part of, so it may be that it was brown at the time of presentation when they were
Yeah,
looking
and I
inside
think
it. It's been revealed as a blue eye.
The next person.
Yeah, I don't remember him being brown when we saw him. Like, I think his iris was really hard to see.
Interesting.
And because we were wondering if it was just like severe, like hypoplasia
Right.
of
Yeah.
this kind of thing. So I will look back through his record and see, but I'm pretty sure I have a note that specifically says that like saw a photo from owner. Like
It was
had
blue.
normal, like
All
consistent
right.
blue iris or something. So
Okay.
yeah, let's add that note to the.
We will do so, yeah. So, yeah, it's good to know. I
Yeah.
mean, you can see that from low magnification here, it looks like a pretty low pigmentation iris, although it's difficult because it's mostly occupied by neoplastic cells at this point.
We had this
Um,
one case a while ago from a boxer that was obviously brown, and we ended up publishing that, not us directly, but the clinician that sent in. And I remember Dr. D and I, we couldn't agree against, we couldn't fight against that, but we were heartbroken that now we have a brown eye schwannoma of the blue-eyed dogs. Like, oh, come on, it was so neat to have them all blue, but
Probably does happen. It might
doesn't
not
make
actually
me
be
feel
this
good
case.
anything. I don't know why, it's such a minor thing, but I'm like, great, yay,
Yeah.
yeah. Brown. Let's keep them blue. I like this story.
The prognosis for this case. So uveal schwannomas tend to have a pretty good prognosis. As far as we know, they don't metastasize very readily, and if they're completely excised, you'll be okay. There are limited reports of metastasis of uveal schwannomas, though, so it does happen, but as far as we know, not very commonly. The slightly elevated atypia in this case, so some degree of pleomorphism in some areas, and the kind of weird carpety patterns that it's doing in some areas, basically are of unknown significance. Right now, we're just kind of keeping track of it. Don't know if that has any impact on prognosis in particular. It's worth noting that both schwannoma and melanoma are of neural crest origin. They kind of have similar beginnings. And in some cases, particularly ones with maybe more, I would say, elevated pleomorphism in the cells than a case like this. Not so much exclusively this sort of spindle cell population, maybe things like that. You could potentially have a differential of melanoma. And it would be pretty hard to differentiate even with the histochemistry between those two differentials. However, this case, the palisading along the surfaces, the patterns that the cells are making, the fact that most of them are kind of locally amorphism, it's pretty typical of uveal schwannoma. So some things that are worth mentioning.
Good case.
Yeah.
Just a comparison.
Blue
So
eye.
we had a few, well, we have more than a few. We have some of these cases in cats too. And they present similarly. The funny thing again, with cats, like when we kind of start putting together cases in cats, the first 3 or 4 were all green eye cats. So again, you can tell that we don't go out very often because we get excited by things like that. So we were like, oh yeah, showing the green eye cat. Then I don't know, of the next 20 cases, none of them were green. So that went down the didn't pan out, but yeah, so you
Cross that out.
out.
Ignore number 2. Well, I mean, technically it's
Yeah,
true.
that's
Brown
true.
eye as per history. Yeah, in the
That's
comment on this one, we were all like, you said it was a brown eye. Anyway, so we're gonna move on because there's more interesting things to look at.
Devil patient tumors.
Ooh.
Double.
And they're also short, so.
Oh, it's interesting. Okay, right, yeah. That'd be
I believe this is Dr. Brown's first rounds after becoming diplomate of the.
Thank you. I'm very relieved, to say the least. All right, so I'll at least have time for one case. So I'm starting with the best one. So this is the globe from a presumed 4-year-old female spayed domestic short-hair cat. I say presumed because it was a stray cat found by the neighbor. The history they provided is that the cat was spayed and a nucleation of a large left eye was performed. Blood work within normal limits. It was FIV, FEOV negative. Some other clinical findings they reported was ophthalmos of this eye and a periocular mass involving the cornea. And that is it. Nice concise history. So here's the gross image from that globe. Indeed, there is a very large mass. Cornea is up top here, and it is involving the cornea surrounding the globe. On hemisection, we can see that it actually extends through the sclera/cornea to fill the globe, vaguely surrounds this lenticular tissue, and then potentially also thickening our choroid. At the very least, we have some sort of tan effect back here that's causing thickening of the posterior segment. We can't really make out the optic nerve head here, but it didn't look like the mass was involving our optic nerve, which will be relevant later. So get my faculties about me. Okay. And this was a very large globe, so we had to use an extra large slide for this one. Let's see. I don't even know if the subgross is going to do this justice. I guess I should also note that this was a very hard globe. I had to decal this for a while, and even then it was not fully decalcified, and I apologize to our histology lab for that. I'm sure this was very annoying for them. Let me rotate it. All right. So, oh gosh, hands are too shaky to do this. So we have a little bit of cornea up here. It is not very recognizable because that mass that I pointed out grossly is heavily infiltrating, at least like the peripheral to paraxial cornea. Can kind of go over here, and here is that, I can't even move this, it's so big. Move that, there we go. Here is more of that mass. There's the edge of it, and then we can see where it kind of extends through the sclera. I can point out a little bit of normal sclera, perhaps. Here's our normal sclera, very thin. You can see where it extends through into the globe itself. Some things that we can also pick up on this subgross view is that there are these really densely basophilic areas. So this is mineral. And then maybe these kind of slightly more pale basophilic areas that we'll look at a little more closely. And here's the region that vaguely looks like lens. It is lens, but a little bit hard to tell. There aren't really any more lens fibers present. That mass is heavily circumferentially surrounding this lens. And then additionally infiltrating the choroid back here. All right. This is going to be, there we go. All right, so cornea is going to be on the left here, again, cornea, but let's look at the features of this mass. So in a lot of areas, we really don't have much of a cellular population to speak of. What this all ends up being is variably mineralized bone. I did decalcify this, so there's probably a lot more mineral present before I decaled it. But then as we get to the periphery, there are these more densely cellular regions. So let's get a little bit closer. Even closer. All right. So this is a homogeneous population of cells. This is a neoplasm, if we were questioning that. And it is composed of spindle-shaped cells that are arranged kind of in a solidly cellular area here, but oftentimes they're surrounding and becoming embedded within this eosinophilic matrix, which is osteoid matrix. And they exhibit mild to moderate pleomorphism. So this area, they're a little bit more bland looking, but from this view, we can at least see that they're pretty mitotically active. I think my mitotic rate was 85 or something in that realm. I probably could have gotten more, but decided to cut it off there. In addition to that, we also have these large expansile areas of necrosis. So all of this kind of paucicellular material here. Look a little bit further where they actually go into the globe itself. So this is going to be in the region of our lens. And again, it's a little bit hard to make out any lenticular tissue. I think there is a little bit of lens capsule. Trying to see if I can find a more recognizable area of it.
I think I saw some pink.
Yeah, like that little wispy.
Yeah, if you go.
Yeah.
Yeah, there.
Yeah. It's like, where'd it go? Yeah, we have a little bit of our posterior lens capsule here, which is discontinuous and kind of just free hanging out within the globe itself. And adjacent to that, we have more of this neoplastic population. Really, this is where it gets a lot less cellular. And we just have more variably demineralized bone. And there are some regions where we have cartilaginous tissue as well. So it's been decalcified, so it's hard to see the cellular details quite as well. It's been a little bit burned. But we do have these neoplastic cells that are embedded within this cartilaginous matrix, and they kind of look like chondrocytes. Again, a little bit hard to make out that detail, but they're there. Okay. So those are kind of the features of this mass. As Dr. Clemens says, not to beat around the bush, but this is consistent with a osteosarcoma. The fact that we do have this circumferential involvement of the lens around this ruptured lens capsule is most consistent with a feline post-traumatic ocular sarcoma of the osteosarcoma chondrosarcoma variant. It's a big mouthful to say. And pretty much everything else associated with this globe is just secondary to that. So we just have heavy inflammatory infiltration of the cornea. There is a corneal ulcer. So we have loss of our corneal epithelium here. There are multiple breaks in Descemet's membrane. So here's Descemet's membrane right there that becomes discontinuous. And then, as I mentioned, this mass also does efface the choroid. We don't really have any recognizable choroidal, or there's a little bit, some choroidal tissue. And there's no recognizable retinal tissue. Unfortunately, we don't quite have our optic nerve head in section here. I imagine for our histology lab, it was kind of hard to recognize where that was going to be since this globe was heavily effaced and distorted. Of what we have of the margins, it does appear complete. So we do have non-neoplastic tissue that is overlying this neoplasm. 60x is not going to help me. There are some areas where it does become a little bit narrow, but still seems to be complete. The only other margin that we would want to assess is going to be this optic nerve. Grossly did not look like the neoplasm was involved in the optic nerve. Even here, it looks like it's pretty well separated, so I suspect it will be clean, but we did request deeper sections, so those are pending to fully assess the margins. So next. So as I mentioned, this is all consistent with the feline post-traumatic sarcoma of the chondrosarcoma osteosarcoma variant. So this is still going to be of lens epithelial origin associated with a traumatic defect in the lens capsule. The osteosarcoma chondrosarcoma variant is going to be the least common of the ones we see for feline post-traumatic sarcoma. I guess unless we start recognizing post-traumatic histiocytic sarcoma.
Yeah.
We'll see about that. And some prognostic features that we can comment on is whether or not there's scleral invasion or dirty optic nerve margins. So those are going to be predictive of local recurrence or extension to the brain. In this case, as I showed in the gross and histologic image, we do have scleral invasion. However, we can't quite comment on the optic nerve margins yet. And this is a super aggressive tumor. We did mention that there are narrow margins, so at the very least, just monitoring the surgical site for recurrence would be prudent in this case. And I think that is it for this one.
Yeah, the history is consistent with these cases, like an adopted cat that some type of minimal history or a history of having a long-standing eye disease of some sort. So that tracks with the expected epidemiology of something like that, which there's a traumatic event, lens capsule rupture, transformation of the lens epithelium that can take a variable amount of time, but it's usually a long time to develop.
Yeah, they said this cat was 4 years old, but it was found as a stray, so
Right.
adult cat of unknown age.
If you ever have a phesical cat eye that somehow becomes ophthalmic later on, it's worth being very afraid.
Yep. It's a good point. A small cat eye that potentially had some trauma that all of a sudden starts to become big. It could be a tumor growing in there. Good. Yeah, I think we are right at the time.
Yeah, perfect.
Thanks, everyone.
Thank
Good job,
you.
everyone. Thanks for the presenters and everyone that coming here. See you in a couple weeks.
Thank you.
Oh, sure.
Yeah.
When clinically,